Hey, good morning, everyone, and welcome to UroNurse. Nice to have you on board. I'm your host, Vic Senese. Great to see you. Hey, if you're watching us live, you can watch us on all of our favorites: YouTube, LinkedIn, Facebook, X, and new Kick. We're trying that out. So if you Kick folks, you're able to utilize this too. If this is your first time checking us out, be sure to check out our website at uronurse.com. Best place to go to see all of our past episodes. We've got a whole bunch of them up there. This is episode 149, so 149 to choose from. Wow, we're getting close to that 150. Some of you like to listen in the car, no problem. We've got our audio podcasts. They come out later in the day through Apple Podcasts, Spotify, iHeart, Amazon, YouTube. Just subscribe through whatever one you like to use. It'll automatically show up in your inbox. You'll be all ready to listen to us in your car on that commute home. So this week, we've got a different show. We're going to be doing a one contact hour on clinical consultation, guiding patients with genital psoriasis towards relief through a multidisciplinary approach. And that's going to be with Tina Bhutani, dermatologist, and Rajal Patel, a OB-gynecologist. Those two physicians are going to be talking about how they treat this. And I thought it'd be kind of an interesting change. Also, it's good for one contact hour, so let's go ahead and get going on that.
Hello, and thank you for joining us for the CME activity on genital psoriasis. This program is brought to you by Physicians Education Resource and is supported by educational grants from Arcutis Biotherapeutics Incorporated and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC. I'm Dr. Tina Bhutani, a board-certified dermatologist practicing at Synergy Dermatology in San Francisco, California, and I'm joined on this program by Dr. Raj Patel. Dr. Patel, would you like to introduce yourself?
Sure. I'm a board-certified OB-GYN practicing gynecology in Chicago at Northwestern University.
Thank you for being with us. In this program, we're going to focus on a variety of issues related to genital psoriasis. We're going to talk about the impact of this disease on patients, considerations in diagnosing patients, and individualizing treatment with a range of therapies. We've got a lot to cover in the next hour, so let's get started. All right, so let's start our discussion on the impact that genital psoriasis has on a patient's quality of life. Now, I'm really excited to talk to you, Dr. Patel, because, obviously you're probably seeing a lot more, dedicated genital psoriasis than we are in our dermatology clinics. And what I found from my clinical experience, although I think we still need a lot of studies specifically around this, but what I found is that patients with genital involvement, whether they have plaque psoriasis on the rest of their skin or not, do have a higher impact on their quality of life. We talk a lot about, it doesn't matter the exact body surface area, right? Because genital psoriasis is going to involve only a little bit of their technical body surface area, but that area is just so sensitive to patients and can really impact their social interactions and how they feel about themselves and how they view themselves, that there is this huge impact on quality of life. So I would love to hear kind of what your experience has been in the discussions that you have with your patients.
So I think what patients don't realize is that studies quote up to 75% of people who have psoriasis will have genital involvement.
Mm-hmm.
And I think that is, I think it's often missed, and we don't ask about it.
Mm-hmm.
Or the patient's not going to know that, what I have going on down there it has to do with my psoriasis.
Right.
Rarely does a patient have only genital psoriasis. Usually they have psoriasis elsewhere as well. Some of these times I've actually seen a lot of women as a gynecologist come in for a vulvar rash. And then, by the way, when I examine the rest of them, by the way, I also have this behind my ear. And I also have this on my scalp. Can you take a look at it? And so sometimes I'm the first one to diagnose it and then send to my dermatology colleagues.
Wow. Awesome. They're very lucky to have you because I don't think, a lot of OB-GYNs, for example, are very aware of psoriatic disease. So I think that's great that you're taking that extra time to do, the skin check in other areas. I'm curious from your perspective, you mentioned that, genital psoriasis alone is pretty rare. Usually there's some other manifestation. Is it usually plaque type psoriasis that you're seeing? The typical psoriasis that we talk about on the elbows and knees, kind of the extensor surfaces, the areas like the belly button, the gluteal cleft, those are like our prototypical plaque psoriasis areas. Or are we talking about more inverse psoriasis, or what we call intertriginous psoriasis, which, includes the genital area, but can be in areas like the armpits, the axilla, under the breasts, in our fold areas, which is not the more common type, but we see a lot of it. And again, not mutually exclusive either. But I'm curious to know in your cases what you see more often.
What I'm seeing more often is plaque psoriasis, but I also do see the inverse psoriasis. But that's really that's a very difficult diagnosis because there's so many rashes that can look like that.
Absolutely.
And that's where the biopsy is important and is really helpful.
Yeah, exactly. And when you usually do a biopsy in these areas, how many times are the biopsies definitive? Like, do they say this is definitely psoriasis? And how often is it a little bit more ambiguous, the
Yes.
answer?
So I am very fortunate to work at a very large academic institution where we have dermatopathologists who are specifically focused on genital dermatopathology. So because of that, I do think that I get that definitive diagnosis a little bit more than elsewhere. But yes, a lot of times it's vague spongiotic dermatitis or psoriasiform dermatitis, and the pathologist may write possible etiologies include
eczema or psoriasis or contact dermatitis, right?
Right.
The list goes on, which makes it even tougher. My favorite is psoriasiform spongiotic dermatitis, which leaves me nowhere. That's always the hardest one.
But one little trick that I learned actually from one of my dermatology colleagues was I see so much contact dermatitis. I think it is underestimated how much contact dermatitis can be on the vulva. And one of the ways that we can tell the difference is looking at the creases, the inguinal creases, the genitocrural creases. And usually with a contact dermatitis, they're not involved because you're not putting the product there. But with psoriasis, psoriasis likes to go to those creases.
Yeah, that's a great point. I love that. I love that as a little pearl. So the other thing that I see a lot in my genital psoriasis patients, or I should say my psoriasis patients with genital involvement, is the presence of itch. These patients, are really uncomfortable oftentimes, and I think that probably also contributes to the quality of life impact. If they weren't itchy, half the time I don't even know if they would know the rash was there, but it's become so itchy and so problematic for them that they have a hard time sitting still. They have a hard time, being in places without feeling the need to scratch. And I like to point that out because I think a lot of times we underestimate the itch in psoriasis. We oftentimes think of eczema as that prototypically itchy disease, but psoriasis is quite itchy, and there's some studies to show that there might just be as much itch in psoriasis, as we have with our eczema and atopic derm patients. Yeah. So again, what do you see in your clinics when you're?
Yes, obviously it's a very, very sensitive part of the body, so all sensations are felt with a little bit more.
A little more
But yes, the itch. And I see the itch in many conditions, but also including psoriasis. And I think you mentioned how they can't sit still. They can't, they have this urge to itch or scratch. They have this urge to scratch. But many of these patients are not sleeping. They're scratching throughout the night. It's worse at night. And I don't have a theory. Well, I'm not sure why it's worse at night. Is it because they're just not distracted anymore? Or is there something to it? Because in all of these really itchy conditions that affect the genitalia, it's always worse at night.
Yeah. And actually it's the same with any itchy skin condition anywhere on the body. The itch is always worse at night. Right. And I think you hit the two theories on the head. One is that, you're either just lying there with nothing else to think about now other than the itch. But then we also know that cortisol levels, dip during, evening times. And so it could be biologically that, those cortisol levels drop, your itch goes up. And that's why we're feeling it at night. But I think we still have a lot to learn when it comes to itch and timing and the circadian rhythms.
The way that a lot of my patients have described is that they cannot help it. They have to scratch it. They have to scratch it, scratch it, scratch it. And to the point where then they are leaving excoriations and the skin is raw. And so then that itch turns into pain.
Yeah. Yeah.
So now there's another problem here with the pain plus the itch they're having.
Yeah, it's terrible. It's terrible. So how do you talk to patients? When I think the hardest part for me when a patient comes in and I know they have psoriasis and, now they have genital psoriasis, and now I have to tell them that this is a chronic condition, right? This is a lifelong problem. Luckily, I think the conversations are a little bit different now because we have so many therapeutics, and we'll talk about, that in the next modules. But that to me is the toughest conversation, especially in kind of a younger patient that's going to have this disease for many, many years. So I'm curious to know, how you discuss that with your patients, what tools you provide to them, to be able to talk about their disease with their partners, with people that they're going to be close with. Because I think those parts are hard. Those parts are the hardest part.
Yes. So luckily, psoriasis affects middle age often. And usually I can find something in their medical history that they have that's chronic. And I try to tell them that, look, it's like your thyroid condition. It is absolutely manageable. There might be ups and downs, but we can manage this. And in the same way that if you had a thyroid condition, if you had diabetes, if you had high blood pressure, you would take a medication and you would manage this. And I will help you with this and we'll figure it out. The younger patients are trickier because the younger patients, they think they've been plagued with this and it's going to ruin their life. And first of all, for the younger patients, I see women, I tell them that this is not contagious.
Yes.
And I think, especially with sexual function, that's a major concern, not just in younger women, but of all ages, but especially in younger women. I emphasize that you don't have to do this alone, and we have a lot of resources. We actually have sex therapists at our center, which is really nice. And these therapists are trained with chronic skin conditions and how they could impact a patient's sex life.
Oh, wow. Yeah. So providing them with resources, right? Yeah. I like to also give my patients, the language, just like you said, this is not contagious. This is an inflammatory skin condition. My immune system is on overdrive and it's, attacking places that it's not supposed to attack, like my skin. But you can't catch this by touching me, you can't catch this by interacting with me. I think using those kind of terms can be helpful, but it's still a difficult conversation, right, to have. And it's still, a terrible disease to live with.
And I think it's a little bit different in your practice, but I wear gloves, obviously, when I examine the genitalia. But if they have plaque psoriasis behind their ears or their scalp, then with washed hands, I touch without gloves to show them that this is okay. Like I am not scared of their condition and this is not contagious.
Yes.
And
Yeah, I absolutely do the same. And oftentimes I'll even get the patients being like, oh, no, you don't want to touch that. And I'll actually make it a point to be like, no, I actually do want to touch this. I need to touch this to make the diagnosis. And it's not contagious. So I'm not worried about catching this and bringing it home with me. So that's
and also with a lot of my younger patients, all patients, but especially my younger population, they feel a lot of guilt. I did something to bring this on. This is my fault. But the truth is, this is an autoimmune condition. It was going to show up sometime. It's probably, genetically written to show up. And then once we delve more into the family history, then you learn about, oh, I do have an aunt who has some skin condition that, she was talking about. And especially with like the second or third visits, when they come back, they've gotten a lot more family history as well about not just psoriasis, but also all autoimmune, many autoimmune,
all the other stuff. No, I agree. Well, that's a great point about triggers. So in my clinic, I would say, some of the more common triggers, I would say one is stress, kind of psychological stress, physical stress, huge dietary changes. I have patients that go on kind of these crash diets and all of a sudden their psoriasis flares up. But, I always point to stress as being a trigger. We also see things like infections, strep infections, for example, are a huge trigger for psoriasis, but other types of infections too. So that's something that we look for. Dr. Patel, what other triggers do you tend to see in your clinic when you're seeing patients with genital psoriasis?
Right. So I don't know how much of this is bias, because of course the patient is plagued with these symptoms that are horrible, that are keeping them up at night, and how much they're thinking back, what brought this upon, what triggered this, versus there maybe wasn't really a trigger. But almost every time a patient with genital psoriasis can come up with a trigger.
Interesting.
Whether it be, for example, one of the photos I'll show later, the onset of sexual activity. Another photo I'll show later is the I got a wax.
Right. Yeah.
Some sort of contact dermatitis bringing it on.
Or the trauma, right? Like the traumatic experience. So we talk about keratinization and psoriasis, where, skin trauma can lead to the onset of psoriatic lesions. So I think the wax, potentially, even though it's very superficial, I think might be enough of a trigger in some areas, especially the sensitive areas, like you said.
Right. And sadly, trauma.
Yeah. All right. Well, I think we're going to move on to our next module so that we can start to talk about the clinical presentation.
So let's start off this next section with a case. This is a case I have of a woman who was diagnosed by biopsy with genital psoriasis. This is a 35-year-old, newly sexually active, obese woman with an itchy, fissuring rash. And of course, this is the first time she had been abstinent until this time. She was newly sexually active. She came in, thought, I have an infection. Something's wrong.
Yeah.
And then I took a look, and the reason I mentioned that she had a high BMI is because yeast is very common, and her yeast culture was negative. I had a low suspicion for yeast because in her inguinal creases, you also see that she has the rashes present there as well.
Right.
Yeah, and it's very well demarcated, especially perianally, everywhere really. And it has that classic look of the plaques with the flaky skin, the scales.
Yeah. And so when you talked to her, did she have psoriasis in other areas when you looked?
So yes. So she actually said, oh yeah, sometimes I do have a lot of dandruff. And when I looked in her scalp, she definitely had some psoriasis there, but she never recognized it because it really wasn't symptomatic other than the dandruff that she was experiencing.
Yeah, absolutely. Yeah, I think what stands out to me from these photos is also, like you said, you see that well demarcated, those red plaques for this patient, but oftentimes not as scaly, right, as we would expect.
Right.
So, when we look at psoriasis in other areas, we expect there to be more of that, plate-like silvery scale. We often talk about this micaceous scale, sometimes people call it.
Yes.
But in the intertriginous areas, including the genital area, we don't often see that scale. And so it looks different both to providers, but also to patients. Sometimes they don't realize that the same thing going on.
She actually did have some on her labia majora, as you can see.
Yeah, she does have a little bit.
Yeah, she had a little bit, which was that plus how demarcated it was, plus it was involving the creases. That's what kind of sort of gave it away that this was obviously not an STD, not a yeast infection. This is a skin condition. And her gluteal crease is also involved.
Right. What we call the gluteal pinking sometimes. So I guess your approach. So again, I think in your clinic you have the luxury of patients coming to you, and if they already know they have psoriasis, they're coming to you because they have genital psoriasis and maybe it's tough to treat or they want more information. But in my clinic, oftentimes, I'm seeing psoriasis on the skin. Even if I'm doing a full body skin exam, many times the patients still have their underwear on. And so it becomes sometimes an uncomfortable conversation because patients will say like, no, I don't have anything down there, or or, there's nothing to see there, I have something, but I don't think it's related to my psoriasis. These are oftentimes things that come in. And so in my clinic, I think I've been trying to make an attempt to normalize it a little bit more that, well, this is a very common area that, you can have psoriasis in both men and women. This is something that I talk to them about. Psoriasis, in addition to presenting on areas like your elbows and knees, can come up in skin folds. And especially if it's my first time seeing them, I really like to do a full body skin exam. Even if you don't have disease in these areas, I just want to have a baseline so that if you were to develop disease in different time, at a different time, that we would know that this is new onset and this looks different. And so I'm trying to kind of set the stage just to let them know that it's totally normal to have psoriasis in these areas, that it's totally normal for me to examine them. But I still run into, a lot of pushback there. And I think that's why I mentioned the scale situation, because a lot of times I'll take a look and I'll be like, I think you have, psoriasis in your vulvar area. And the patients will say, oh, I thought that was just a yeast infection, or I thought that was totally different. They don't link the psoriasis on the rest of their body to, the psoriasis in their skin. So I think we need to do a little bit of a better job about, again, just making that full body skin check, including the skin fold areas, routine in our full body skin exams. I think that's something that we can definitely improve on in dermatology.
I think we can all improve on collaborating for the care of these patients, right? Yeah. I have had patients come to me and say that I asked my provider to look down there, but they said, go to your gynecologist. Yeah. Versus as a gynecologist, this is not something that you see often in training.
Yeah.
I could probably count on one hand the number of times I've seen psoriasis in my training.
Yeah. Yeah. No, it's very true. It's very true. Do you have, when you're doing a genital exam, I think the other thing that, oftentimes dermatologists, back in medical school, we all theoretically learned how to do a formal genital exam. But it's, it's been forgotten. It's been a long time. And so when you do a genital exam, do you have any tips or tricks that you would provide to dermatologists, other than obviously the draping, and we know kind of, getting patients to feel a little bit more comfortable by covering up areas that we're not examining. But anything else that you would advise when when doctors are doing a genital exam?
Yeah, I think, like you said, normalizing it. I think that's so huge. And patients would feel so much more comfortable if the dermatologist said, hey, take off everything, let me take a look, right? Normalizing it and saying, and maybe even providing a statistic that, hey, up to 75% of patients have psoriasis in the genital area, and it can look really different. So if you don't mind, let me take a look. I start by, after the draping and all that, I start by checking the inguinal creases. I take a look at the mons. And then if you look at my exam template, I have about 14 different lines on just the genitalia. So labia majora, minora, the interlabial sulci, the prepuce, the clitoris, the vestibule. So we're kind of looking at each part, because I think even many general gynecologists are going to sort of go for that speculum exam.
Yes.
Where you're not really examining the vulva in detail.
Yeah.
I had one of my professors describe it as the town that you sort of just drive through to get to the big city.
Yeah, no
one's paying attention.
Yeah, exactly. But yeah, in this case, this is where, where the bulk of the exam is going to be, right?
Right. Yeah.
So for me, when I'm, seeing a vulvar rash, I think, you mentioned in the previous module, but, other diseases that we might think of, like on our differential, we mentioned, things like eczema, contact dermatitis, right? Those are things that I think very commonly come up. Like psoriasis would be on the differential, although, a little bit different, exam. Are there other things that you would add to the differential diagnosis of genital psoriasis?
HS, hidradenitis suppurativa, can look very similar in some cases. Lichen simplex chronicus, eczema, as you mentioned. I'm trying to think what else looks like. Crohn's disease. But Crohn's is usually much more dramatic. Trying to think what else.
Yeah, no, I
But I'll
think those
stop
are,
here.
and like you said, HS, especially if they have a lot of secondary changes, right? Like that, like in simplex chronicus, like
Right.
if they're picking or if they're scratching. I totally agree. I think HS can sometimes be tricky to diagnose. So I think, a few years ago, there was a study that showed that, psoriasis in special sites is actually a risk factor for developing psoriatic arthritis. And so again, we talk about nail psoriasis, we talk about scalp psoriasis, and these are areas that are, commonly linked to psoriatic arthritis, but actually genital psoriasis was also on that list. So I think that's another important question that we should be, asking our patients, not only looking at other areas of their skin, but, asking them about joint pain, swollen digits, stiff joints in the morning, stiff back, stiff neck, things like that. I think those are all questions that could also help to lead us to see if they might also have psoriatic arthritis, because that's something that we see in sometimes, a third or more of our patients with psoriasis. So I think that's important to remember as well.
I think we're all becoming very specialized. And, I'm saying that as a gynecologist who does vulvovaginal disease, but that review of systems, this is where that comes in to capture what else could be going on in the rest of the body that might be related.
Yeah, you're so right. I mean, we know that psoriasis is associated with so many comorbidities now. The data keeps coming out every year, and the list keeps increasing of diseases that are oftentimes more prevalent in our patients with psoriasis. So, I already mentioned psoriatic arthritis, cardiovascular disease, diabetes, obesity, as you mentioned, in this patient. Inflammatory bowel disease, right? Many of our patients also have IBD. Sleep apnea even is on that list. We have so many different diseases, and I know it's hard to check for all of these things, but I think it's just good to keep an open mind, because if a patient does happen to mention something that you think might lead you in the direction that they could have some other diseases, I think it could be helpful, because oftentimes we have to treat these diseases concurrently, right? And we'll talk about that a little bit in the next section. But that can get complicated, right? When you have two different diseases and we're trying to manage both and trying to come up with therapies that are going to be helpful for both of those. Great. Any other pearls of wisdom here before, as far as the clinical presentation of genital psoriasis goes, before we move on to treatments?
I have another case. I don't know if
Oh, perfect. Yes, let's do it.
And I think this case highlights that it can look really different in people, who have color.
Skin of color. Yeah.
So this is a patient. This is a 40-year-old, presumably healthy female who, with a history of herpes, also genital herpes, and her symptoms started after a wax. So the first thing that she's thinking is, gosh, I have herpes again, right? I have an outbreak. But this looks nothing like herpes. As you can tell, that this is much more involved. Usually herpes is just, a very small area of the vulva, especially if it's a recurrence or but here you can see that it's involving quite a bit of her vulva. And the point that I want to make is that the psoriasis can look very different in patients with skin of color, especially Black patients, Hispanic patients, Indian patients. So this is something that another pearl that I've learned with practice over the years is that if you're taking your exam light, which has a very, very shiny yellow light, and putting it on to the vulva, you're going to miss it, because the gray is you're not going to be able to see the gray. So the gray and the purple and brown, these are the changes that occur, not the red and the pink and the scaly necessarily. And so usually what I'll do is I'll take the light away, turn on the room lights, and then take a look that way. And I also have the patient look with a mirror. I say, look, this is what your skin looks like. Is this normal for you?
Yeah. No, I think that's a great point. We prototypically textbook psoriasis, right, which is usually on Caucasian skin, we see more kind of red, pink, salmon colored plaques, sometimes.
Right.
But in skin of color, what we see is more brown, violaceous, purple, as you mentioned. And so that's a really important point, and something that I think, even dermatologists are not trained well in. And so I think that's a great point.
So this is the same photograph of this patient, and perhaps in somebody who's not used to seeing psoriasis, this looks not that dramatic. But when I point out, I try to outline to the best of my artistic ability on paint, the yellow areas of how much involvement that they have.
Yeah.
So all of this is gray, and you could easily miss, but this is very different from the rest of their color. And also this hypopigmentation that you're seeing here.
Yes. Yes. And that's a great point too about the hypopigmentation, hyperpigmentation that sometimes we even see after the psoriasis has been treated, especially in patients with more deeply pigmented skin. And sometimes that can be scary to patients because now they're feeling better, their itch might be a little better, but they still have this hyperpigmentation and they're like, I still have this going on. So that's another point I think we have to spend a little time educating patients on, is also this post-inflammatory changes that can happen even after the disease has gone away.
Yes. And also setting expectations, especially if the patient has darker skin, that I can't promise you that the color is going to come back.
Right.
But this is not, the way it looks is not how we're going to base the activity of the disease on. That it's more about the way it feels and the other characteristics, because the hypopigmentation may last.
Yeah. Yeah. Great points. Any other points to share here?
This is, I think, more getting into the treatment, but she was obviously started on clobetasol and a prednisone taper because she was so incredibly itchy. And then 2 weeks later, she was not much better, but also complicated by a yeast infection at the same time, treated with fluconazole. And then my dermatology colleague did start a biologic.
Okay, great.
And more recently changed to a different biologic, because the yeast is just not getting better. And I can't comment on whether this biologic is better for infection versus the other. Yeah.
So how often are you biopsying patients with suspected psoriasis? Are there ever times when you just know it's psoriasis and you say, no, I don't need to do a biopsy? What is your practice there?
So in the first patient that I showed, this one, I wasn't the one who biopsied her.
Okay.
But if I had seen this case, I think this is so classic that I would have felt comfortable treating her for psoriasis. And then if the treatment doesn't work, then proceeding to a biopsy.
Yes.
Yes. Yeah. Whereas in the other patient that I showed, this could easily be something like lichen sclerosis or lichen simplex chronicus.
Yeah.
Yeah.
Yeah, I totally agree. So I think, if it's a really classic presentation, if they have other areas involvement in other areas of their skin, for example, or they, have known psoriatic arthritis, then obviously it makes the diagnosis a little bit easier. And so I might just move on and try some type of empiric treatment and see if it works. But if it, looks funny at all, or if they're not responding to the treatments that I am prescribing them as I would have expected, then those are the times that I lean towards a biopsy, because obviously biopsy in the vulvar area is not the most comfortable and not the most easy thing to do. Oftentimes or to convince people to want to do.
Right. But Dr. Bhutani, I think that we also have the luxury of specializing in something like this, right?
Yeah.
And so, before I specialized in this, I practiced general gynecology. And at that time, I would have biopsied just to triage the patient better, to know where to send them.
Yeah.
So I would never fault somebody for biopsying a patient. It's only useful information.
Absolutely. Absolutely. I totally agree. Now let's take some time to discuss opportunities in managing these patients with genital psoriasis. We're so lucky that we are practicing in a day and age where we now have, multiple different treatments for our patients with psoriasis. And so, we usually divide our treatments into, different sections. So we have, obviously topical treatments. We have phototherapy that can be used, for patients. We'll talk about specifically in genital psoriasis, how that might play a role. But then we also have now systemic agents, right? We have oral agents, we have biologics. So we have this whole toolbox to choose from. But oftentimes, it can still be challenging despite having all of these different options and trying to figure out, what is the right option for our patients. So let's start a little bit with topical therapy. So, we have obviously our topical steroids, which have, always been the workhorse in dermatology, and we still continue to use a lot of them. But we have lots of non-steroidal agents as well. We have our topical calcineurin inhibitors that oftentimes get used. We have vitamin D analogs. But then now we have a whole new classes of topical therapy, non-steroidal topical therapy. We have topical roflumilast cream, which is a topical PDE4 inhibitor, and then we have topical tapinarof cream, both of which were approved in the last few years. So I'm curious, Dr. Patel, in my practice, I think that I am now with the advent of these new non-steroidal topicals, I think when I'm treating someone topically, when I feel that either their disease is pretty limited, maybe they don't have a lot of disease in other areas, and I think that topicals could be a good treatment for them, or maybe they're already on a systemic agent, right? But they still have some stubborn areas. I think those are the areas where topicals play a role. I still, like I said, I still use a lot of topical steroids, but I think my practice is moving a little bit more into using, a little bit more of these non-steroidal agents, because I don't have to worry if they go home and they use it every day and all day,
Right.
and
Right,
put it all over their
exactly.
skin. It makes me feel, a little bit more safe when I'm using those agents, and they're also, really effective. So I'm curious how they're playing a role in your practice.
Sure. I tried very hard to start a tacrolimus. Is that how you pronounce it? I say tacrolimus.
Tacrolimus.
Yeah. A trend. But while it works very well for other areas of the body, one of the biggest complaints that I get is that this burned. This burned so bad that I will never try it again. And then so usually I do start with a topical steroid because the reaction risk is really low.
Yeah.
If it's very severe disease, I will start with a much higher potency steroid. But something like a very mild steroid, I worry much less about them using it on a daily basis, or a very, overusing it.
Yes. Agreed. And, I think that's an important point to remember, because a lot of these topical steroids even, they have a limitation on the label, right? That we can't use them more than 2 or 4 weeks, which is really tough, because as we know, these are chronic diseases. We're probably definitely going to need them for longer than 2 or 4 weeks. And you write the prescription, they go to the pharmacy, and the pharmacist tells them to stop it after 2 weeks, and then you're back in the office with a flare-up.
Yes.
So I think that's a really important point, is that we need to educate our patients that it is okay to continue this with close monitoring. As long as I'm following you and as long as I'm monitoring you, these medications should be safe. Even if we should start to see a little bit of skin thinning or any issues, those problems are reversible as long as we catch them at an early stage. So.
Right. And I think that counseling is very important, because they are going to go ahead and read, what comes with the medication.
Oh, yeah, absolutely.
And they're going to get diabetes, they're going to gain weight, they're going to get glaucoma. Is it glaucoma? I don't actually remember what it is.
If they use it around the eyes, if they use it on the face.
But these patients worry about all the things that come on the list that comes with the product, right? So I usually tell them, your product is going to come with a list that's going to tell you that you're going to have all of these negative effects. It may even tell you you're going to die from this.
Yes.
If you're not going to die from this, right now, your skin really needs this.
Yes. Absolutely. And I think the other thing, and I learned this from my OB-GYN colleagues, is, I think as dermatologists, we sometimes shy away from using super potent topical steroids like clobetasol or halobetasol in the genital area, because we're always taught, right, that those medications are too strong to use in the groin.
Yes.
And so, but, in many diseases, for example, like in sclerosis, many diseases, you need those super potent topical steroids. And I learned from my colleagues in OB-GYN that I shouldn't be as scared of those medications in those areas. And so again, with close monitoring, short-term use, I think even super topical steroids could be an option.
Absolutely.
I completely agree with you that I think a lot of us have been quote unquote burned by the older non-steroidal agents, because things like tacrolimus or pimecrolimus, they can burn when being applied to the skin. And that's why oftentimes we will just use them for maintenance, clean it up with a little topical steroid and then transition to maybe those agents for maintenance to make sure the disease doesn't come back. But again, with some of these newer non-steroidal agents are really well tolerated, that I think they don't necessarily need to be only maintenance agents anymore. I think we have the luxury of using some of these, even first line. Question is always insurance coverage, right? These
Yes.
newer medications are obviously expensive. They're sometimes a little harder to get, but if I can get them, I've had really great luck with them, and I think patients tolerate them really well. And then they can use the same medication all over the rest of their
Right.
body, right? Like one prescription, use it anywhere. Again, you're not drawing out a map of which medication you're going to use where on the body.
And we've done that, we've done that before.
Yeah, exactly. So I think in those cases, those topicals can be really helpful.
Speaking of the map, I do tell patients to use a little bit of caution around the anus because that skin can be really thin.
Interesting.
So so that should be the minimal amount of high potency steroid they can get on there.
Okay.
Just right around the anus because that skin's so thin.
Got it. And also kind of an occluded area, right? Where it can increase the penetration of the medications when you're using it in that area.
Exactly. Yes.
Yeah. Great point. So I mentioned, phototherapy as an option. I don't think, we don't use a lot of phototherapy in the genital area. First of all, things like narrowband UVB, it's just not accessible. Like you can't really treat the genital area in that way. I think, excimer laser could be one loophole there where, if a patient did have genital psoriasis, theoretically you could use excimer laser. But I think most of the time people shy away from that. Narrowband UVB we know is very safe, doesn't increase the risk of non-melanoma skin cancer. But the one exception might be in the genital skin because there have been studies that show that patients that were treated with narrowband UVB, these were male patients, but still they could have an increased risk of genital squamous cell carcinoma. And so I think we still shy away from phototherapy as an option there. So I don't think that's the best option for the genital area. But systemic agents, like I mentioned, we have a lot of oral systemic agents. We have now a lot of biologic drugs. And we have, specific data, I think, in that area with regards to genital psoriasis. Many of our psoriasis biologics looked at genital psoriasis in their clinical studies. Some even had, dedicated trials. One example is the Gulliver trial with one of our newer drugs, guselkumab, where they looked specifically at facial and genital psoriasis. So I'm curious to know, what is your threshold? When do you say like, this is a topical candidate versus this is somebody that needs to, step it up and move on to systemic therapy? When does that switch turn in your head?
Sure. So as a gynecologist, if they come to me and, and they're in that state where they're scratching throughout the night, their sheets are bloody, then I will go ahead and treat aggressively with a short-term course of oral prednisone.
Yes.
I will give them an antihistamine at nighttime to prevent the scratching. Sometimes even at something like gabapentin or tricyclic, such as amitriptyline, nortriptyline.
Yeah.
And I'll give them the topicals, of course, in addition. I have also done antibiotics, not because I think they're infected, but because of their anti-inflammatory properties. So I have this cocktail that I give them just to get them under control to the point where they can then transition to only topical.
Okay.
If I can't get them under control with just topical, let's say there's focal areas where they're especially struggling, then I'll go ahead and do an intralesional steroid injection.
Mm-hmm.
If that doesn't work, and I've tried my tacrolimus, then I really look toward my dermatology colleagues for help.
Which drug should we pick next, right?
Yes.
Yeah.
So I'm very lucky to have colleagues that, we collaborate on these patients quite a bit.
Yeah. And, I've heard from a lot of patients, like, I mentioned earlier, sometimes the body surface area involvement with genital psoriasis is very limited, right? They might just have like 1 or 2% body surface area impacted. And people might say, well, that's not, moderate to severe psoriasis. We can't prescribe them with, a biologic agent. But it's important to remember that many society, National Psoriasis Foundation, International Psoriasis Council, the definition of moderate to severe psoriasis is either that they have, greater than 3% body surface area. So I like to remind people, the National Psoriasis Foundation calls moderate psoriasis is only 3%. So they don't have to have tons of psoriasis to have moderate to severe psoriasis. It's only 3%. Or they have psoriasis in sensitive areas like the genitals. So again, genital psoriasis alone would meet criteria for moderate to severe psoriasis. But then the last thing is the impact on quality of life, right? So even if they have limited body surface area, but that body surface area causes significant impact on quality of life, again, that kind of pushes somebody into the moderate to severe category.
Yeah.
And so I think those are all important things to remember when we're treating our patients, making sure we're not under treating them, right? Just because they have limited body surface area, we need to really have the conversation to talk to them about what the impact is on their quality of life.
And I think these patients, thank you so much for understanding that. Do you ever use medications such as methotrexate, cyclosporin, or are we moving away from those medications as these newer biologics are developed?
Yeah, absolutely. I can, count on one hand the number of times in the last few years that I have prescribed methotrexate and cyclosporin. I think with the advent of our newer drugs, we're much safer, require much less monitoring for our patients, just really much easier to use. I don't really use those medications anymore if I don't have to. There's a few scenarios where, for example, one is the insurance company requires me to try it before going on a biologic drug. So that's probably the most common scenario where I'm using something like methotrexate or cyclosporin. But patients with like erythrodermic psoriasis, for example, really terrible flare, I need to get them under control really quick. Cyclosporin's still in the back of my head when I'm thinking about those patients, even though some of our biologics work really fast. Yeah. So getting back to your cases, I'm curious, do you remember the history of those patients and what they were kind of treated with?
Yeah, so the 35-year-old who was newly sexually active with psoriasis, she was successfully treated with topical clobetasol, then transitioned to topical triamcinolone for maintenance, and she did very well, all cleared up by the next time I saw her. The other case I presented is still ongoing because her dermatologist, my colleague, is still working on how to get, I'm helping with the yeast, she's helping with the psoriasis. How do we balance the two?
Yeah. So I think you had mentioned that the patient was started on secukinumab. Was she having yeast infections prior to the secukinumab as well? No, it happened after. And then once she switched to the risankizumab, is that still happening or is it?
To be determined.
Okay.
That just happened.
Oh, got it. Yeah. I think that'll be a great, case example. We do know some, the IL-17 inhibitors might increase the risk of candidal infections, things like oral thrush, but also vulvovaginal candidiasis. Slightly, but not, we don't see a lot of it, but it is a potential. So it'll be interesting to see how that patient does on a different class of biologics and if they get less of that.
Yes, I'm hoping to learn from her as well.
I think, in my experience, I think I've seen really good results with all of the different classes across the board. And I think it really is the same as treating any other part of the body in that, some patients respond really well to some drugs and then the other patients might not respond at all to the same class of medications. And so I think there's a little bit of trial and error involved. But I think, again, like you said, having that collaborative care team is really important and working together and not giving up because, sometimes it does take 1, 2, 3 different tries before you find that like magical combo that works.
Right. And, I'm old fashioned. I just pick up the phone and call their dermatologist. And usually, I mean, it's not usually, it's always a very pleasant conversation. And we are both working to help this patient feel better. Absolutely. And the same goes both, the other way.
Yeah. I've had a couple of patients. I'm curious if you've had any patients like this where I find really tough is where I clear up the skin, no matter what modality I'm using, the skin is clear, but they're still itchy.
Yes.
And do you see that?
Yes, I see that all the time. It's the neuropathic itch.
Yes, exactly.
And the way that I describe it to them is that there was a war. A war happened at your vulva. The war is over, but the soldiers are still there.
Interesting.
We got to send these soldiers home. And this is where the neuropathic meds come in. And this is where I do, in fact, a lot of topical gabapentin compounded. I don't have great evidence. I just have, anecdotal evidence that a lot of my patients do better and
Interesting.
do
I love
recover.
that.
Because I don't love the side effect profile of some of the medications, some of the neuropathic medications. But if I have to, then absolutely, I will go to the oral medications as well.
Great. I love that, Pearl. Yeah, I'm definitely going to give that a try. I'm going to call up my local compounding pharmacy and see how I can get some of that.
The problem is that once the skin is cleared, and if they're not going to somebody who knows skin, who knows that skin, they're often dismissed.
Yeah.
And they think, I don't know what to do because the skin looks normal. Why am I still having symptoms?
Yeah.
But that's very common.
Yeah, I agree. Well, we mentioned a little bit of this earlier, but the importance of this multidisciplinary team, right? So here we are, dermatologists and OB-GYNs working together. I think you mentioned earlier that you guys also have, a sex therapist or somebody that can kind of deal with that, emotional impact or that mind-skin connection that we oftentimes see. Any other people that you oftentimes include in that multidisciplinary?
Yes, I cannot do without the physical therapist at our center.
Yeah.
And especially with this neuropathic pain, right? Because, and sometimes the pelvic floor gets involved.
Yeah.
And they have pelvic floor dysfunction as a result of the symptoms that they've been having on their vulva or vagina.
Right. Yeah. I just learned the importance of, pelvic floor PT. A couple of my patients were referred and just had these amazing results. And I guess I didn't realize that there were physical therapists who specialize in pelvic floor. And we have a few here in San Francisco. But yeah, I think I'm going to be using that a lot more often because again, especially with that neuropathic component, I think that could be really helpful.
Right. Dr. Butani, I really enjoyed talking about this topic. This is something that is very near and dear to me. And to all the learners out there, I hope that you got some tips and learned something. And thank you so much.
Thank you.
All right. Well, I hope you enjoyed that. And remember to go to get your contact hours. Just go to our website and click the button. It'll bring you over. You'll have to fill out a few things, but you don't have to rewatch it. You can just fast forward through the video and you'll be able to get that contact hour. Hope you enjoyed the show. And here's what's going on next week.
Discover how HR healthcare is transforming urology care. Presented by Chris Wiesman, this podcast explores how HR healthcare, a cutting-edge digital health platform, is revolutionizing patient care in urology practices. From improving patient engagement and automating workflows to seamless EHR integration and telehealth tools, HR healthcare empowers urology professionals to deliver faster, more personalized, and more effective care. Don't miss this essential look into the future of urologic nursing and digital health. Join us June 14th at 9 a.m. Central Time to learn more.
All right. Well, we'll see everybody next week for that show. Chris has been on the show before, really great speaker, and their company has got some new ideas and new products to talk about. So it'll be very interesting. Be sure to tune in. We'll see you all next week.